Acute coronary syndrome. Acute coronary syndrome refers to a spectrum of clinical presentation ranging from those where ST segment elevation myocardial infarction to presentation found in a no ST segment elevation myocardial infarction or an unstable angina. It is almost always associated with a rupture of an atherosclerotic plaque and partial or complete thrombosis of the infarct-related artery. Signs and symptoms: palpitations, pain, external dyspnea that will result with a pain or rest, diaphoresis from sympathetic discharge, nausea, and decreased exercise tolerance.
The left shoulder. Happened this morning, went away while working out. It came back a lot worse. Be given 4 baby aspirin, 1 nitro. Pain went from a 6 out of 10 down to a 4 out of 10. We already transmitted the 12 lead.
Hammond, can I get a name?
First name's Jem. Wife is behind us somewhere. She has more information.
Hi, I'm Dr. McGovern, the ER physician. The EKG that the paramedics did in the field is showing that you're having a heart attack. I've already spoken to the on-call cardiologist, and the cath lab is on their way. You're going to need a procedure in angiogram. It's called percutaneous coronary intervention. We're going to put some dye in and look at the vessels around your heart. Nurse, can you activate the STEMI EBOS?
Do we want to repeat EKG?
Yes, can you please get a repeat EKG?
You're going to feel a pinch here, sir. I'm going to draw some blood at the same time.
Oxygen at 2 liters. How's your
Can
chest
I
pain
take a
right
listen
now?
to you, too?
It's a little better. I think something melted in my mouth or something. I don't remember what they said it was.
What's his heart rate right now? 110.
Let's give
His
him
blood pressure is 146/76.
50 of low pressure, 600 of Plavix. Get him on a nitro drip.
Oxygen 96%.
I'll get the meds from the STEMI box.
Respiration's 33.
And paramedics gave aspirin en route, I understand. Is that correct?
Correct.
It's got another IV. It's the right forearm.
I need you to
20
try and lay
gauge.
really still for me, hon. As still as you can for just a minute.
Jim, what kind of medical problems do you have?
I have high blood pressure and high cholesterol.
Okay, and you take medications for those?
I do. Lisinopril and
Simvastatin?
There's a monitor.
Okay. Who's your regular doctor?
It's my family doctor that I just see him, once a year for follow-ups and physicals and
Okay. Okay,
Jim,
that's
we have to
fine.
shave your groin.
Put more monitors on you, sir. The transport.
Yeah, start on
Still
0.9
feel
at
okay?
100
Groin and shave.
an hour.
You doing okay? Yeah? Okay.
Are you having any trouble breathing with this, Jim?
No, it's much better than it was.
Okay, let me just take a listen on your lungs.
Nancy,
Take
he's
some
got
nice breaths for
0.9
me.
saline running at 100 cc's an hour.
Couple more breaths for me, Jim. No swelling. Jim, let me take a look in your throat here. Great, and your eyes, open your eyes for me.
How's your chest pain right now?
It's there, but it's definitely better.
Okay,
Can you rate it on a scale?
Maybe 3.
Chest pain is a 3 out of 10.
like I said, the cath lab and the cardiologist are on their way in. They're going to take real good care of you, okay? Your
Thank you.
pain's already getting better, so that's a good sign.
X-rays here.
So we're going to need to have you sit up and do an X-ray. Can you sit forward for us?
The third and fourth scenes of this video involve the recognition that our patient Jim is having an ST elevation myocardial infarction being brought in by EMS. However, many of our patients present to the ER as walk-in to triage, and this initial recognition and EKG needs to be performed immediately by the triage staff. Jim needs PCI in the cardiac catheterization lab as quickly as possible. Initial interventions are done in the ER to prepare Jim for the cath lab. 2 large bore IVs are placed, defibrillation pads are applied to the chest wall, and bilateral groin hair is clipped. In preparation for transport, a portable monitor and O2 tank is placed on the bed. Portable chest x-ray needs to be performed, and medications from our STEMI box are to be administered. Unless contraindicated, these medications...
A coronary syndrome is caused primarily by atherosclerosis. Most cases of ACS occur from this eruption, non-cerebral lesion, and atherosclerosis lesion that was previously hemodynamic and significant yet vulnerable to rupture. The vulnerable plaque is typified by a large lipid pool, numbers, inflammatory cells, and a thin fluid cap. Elevated demand can cause ACS and present for a high-grade fixed coronary obstruction due to increased myocardial oxygen and nutrition requirements, such as those resulting from exertion, emotional stress, or psychological stress.
Shown by the brown color. That can inflame the endothelial cells, which will express adhesion molecules for leukocytes, or inflammatory white cells, which will then penetrate into the intima, where they'll take up some of the lipoprotein particles and transform into foam cells, the hallmark of the early atherosclerotic lesion, which usually grows in an outward direction. Lesion complication begins when the smooth muscle cells in the intima begin to divide and secrete extracellular matrix molecules, such as collagen. Other smooth muscles will penetrate into the intima from the media, where they will join the other smooth muscle cells in forming a fibrous cap overlying the lipid core. When there's a persistence of risk factors such as high levels of LDL, the lipid core grows and it sets off an inflammatory response. Leukocytes, such as the T lymphocyte, can send signals to the macrophage, either soluble signals, or it can activate the macrophage by contact. The activated macrophage can then secrete various mediators, including matrix metalloproteinases, which are enzymes that can weaken the collagen in the plaque's fibrous cap, making it susceptible to rupture. When there's a rupture of the plaque's fibrous cap, it can cause a thrombus, which when sustained and occlusive can cause an acute myocardial infarction, shown by the ST segment elevation. However, we now know that most plaque disruptions are actually clinically silent, or when subtotal or transient, can cause an episode of unstable angina, shown by the ST segment depression. But when that resorbs, it can cause a healing response that thickens the fibrous cap and narrows the lumen, giving you a stable but symptomatic plaque. When we intervene to lower the risk factors such as low-density lipoprotein, it gives a chance for the lipid to leave the core and allows the inflammatory white cells to depart or die by apoptosis. That gives a thickened fibrous cap and an uncompromised lumen, which will yield a stable and asymptomatic plaque.